Alright guys, we're back again, CT 4071. We are on lesson 3, imaging the abdomen and pelvis, and we're going to talk about the GI system today. The GI system consists of the esophagus, the stomach, the small and large intestine. And some indications for scanning the CT abdomen and pelvis include inflammatory diseases, identification, evaluation, and staging of neoplasms, trauma, and vascular disease. CT is extremely valuable in the evaluation of various complications of the GI processes, and these include perforation, which is a puncture in the wall of the GI. Contents of the stomach or intestine may spill out into the abdominal cavity, which can cause peritonitis, which is an infection that can cause a fistula, which is an abnormal connection between the intestine and an adjacent structure. Fistulas are commonly associated with inflammatory bowel disease, and it can also cause an abscess, or it's a collection of pus that's caused by an infection or an inflammatory process. Most important identifying sign of GI pathology on CT is wall thickening of the colon or the small intestine. Peristalsis used to be an issue, causing some motion in the earlier scanners, but with the multi-slice scanners we've pretty much overcome that problem. It's a lot faster now. So together with oral contrast, IV contrast will enhance the bowel wall further, identifying pathologies such as thickening, wall thickening, mass lesions, inflammatory processes, and vascular abnormalities such as bowel ischemia, which is reduced or stopped flow to a portion of the bowel. We'll see that more pronounced when we talk about CTA of the abdomen and the mesenteric vessels, how they can be constricted and stop or slow down the blood flow to the bowel. All right, so this is an example of bowel perforation. You have over here oral contrast is spilling into the peritoneal cavity, and it's lining the liver from perforated bowel, all this bright area here. And then over here you have a pneumoperitoneum from the perforated bowel. The arrows indicate the falciform ligament here, and the falciform ligament connects the liver to the abdominal wall, and when it's outlined by air, as it is here, that's a sign that there's free air in the supine patient. You know, make sure the patient's supine, but when you see the falciform ligament outlined with air, then you know there's a bowel perforation. Also, there is the double arrowheads here, or the thick arrowheads here, indicate a double wall sign, and that's an air outlining both sides of the bowel wall. So you have some air in here outlining this bowel wall, and then air out here. That's a big sign that there's a bowel perforation going on. And you don't want these patients to have drank barium. You want them to have some iodinated contrast, water soluble. Okay, here's an example of a fistula. This is a rectal CT barium in the rectum. It's placed in the rectum. Here's the catheter and the bulb of the enema tip. And in the vagina, there's contrast in the vagina because of that rectovaginal fistula connecting somewhere, probably right here. That's just not on that slice, but a fistula has formed between the rectum and the vagina. And then here's an appendiceal abscess, just to show you what an abscess looks like. You have a lot of dark fluid collecting, and then you have some stranding going on in this tissue out here, and then all of this bowel wall that is inflamed as well. And here is bowel ischemia, or dead bowel, as it's sometimes called. The yellow arrows are the bowel wall that's enhancing with IV contrast, and then you see over here this ischemic bowel is not enhancing. There's no IV contrast flowing through the mesenteric vessels, highlighting this bowel because it's not getting there. So that bowel is becoming necrotic. And will be if it's not surgically intervened. So let's start at the beginning of the GI tract with the esophagus. The esophagus appears briefly in the abdomen, CT scan, but it may be scanned more superiorly in the thorax or the neck, as clinically indicated. But it appears as an air or a contrast-filled cylindrical structure on CT, as we've seen in the thorax. And the CT of the esophagus can be, the esophagus may be enhanced with barium paste swallowed just before scanning. The thin barium, of course, is not going to work. It's going to flow right through, so you have to have the barium paste so that it will be thick enough to adhere to the walls and outline the esophagus. The CT of the esophagus is done primarily for neoplasm and malignancy staging. The other indications are esophagitis, which is characterized by esophageal wall thickening. We can look for foreign bodies, esophageal varices, which are dilated veins, and hiatal hernias, which it's a protrusion of the GE junction through the diaphragm into the thorax. And those can be quite large sometimes. We'll have to go way up to on our top scan lines to catch that. All right, for the stomach, just some facts about the stomach when we scan it. It's not usually scanned by itself, but when it is, it must be distended with positive or negative contrast or both. Water is it's effective for visualizing the enhancing gastric mucosa when you give IV contrast. Oral contrast amount should be 150 to 250 milliliters given immediately before scanning. Then also the stomach can be distended by effervescent granules, just like in the routine fluorine where we give the gas crystals before we give the barium to inflate, and the stomach you can do the same for CT. And for the upper abdomen to include the stomach, your patient should be fasting at least 4 to 6 hours so that there's no food or anything else in there that can be mistaken for a mass. Indications for specific evaluation of the stomach include benign and malignant neoplasms, lymphoma, hiatal hernias, and assessment of complications due to bariatric surgery, which is weight loss surgery. Sometimes those incisions or those connections can leak, those anastomosis can leak, and CT is good at picking that up. The small intestine is also surveyed in the CT and pelvic scan. It's divided into the duodenum, the jejunum, and the ileum. The duodenal bulb connects with the stomach via the pyloric sphincter. The ileum leads to the large intestine via the ileocecal valve. Now, up in the stomach area, you have the ligament of Treitz, and that's a duodenum that suspends the duodenum from the diaphragm. Those are important in infants as well, because they can be born with their duodenum all twisted up because of that. Oral contrast for the small bowel, you need at least 750 milliliters or more to completely opacify all the way to the ileum and the proximal colon. And that may take them an hour or so, just like a small bowel follow-through would. And the advantages of a study called CT enterography, we briefly covered that in another course. We'll cover it a little later in this course, but it displays the entire thickness of the bowel wall, and it allows examination of the deep ileal loops of the pelvis without superimposition. And it also permits evaluation of the surrounding mesentery and the perienteric fat. CT enterography also allows assessment of the solid organs and provides a global overview of the abdomen. And like I said, we'll go into more detail about that later in this course, but just know that it's another study that we do for the small bowel in CT. So external hernias in the small bowel are very, very common. There are many types, but The ones that are most popular include the inguinal hernias, which are the lower anterior abdominal wall at the region of the groin. The umbilical hernias are at or near the umbilicus. They're most common in pregnant women and obese patients. And then you can have incisional hernias where there's surgical complications. You could have wound dehiscence and some other complications. So here's examples of external hernias. Here is an umbilical hernia. You see the bowel protruding through the abdominal wall into the umbilicus here. And then the inguinal hernia, this little bowel loop here that's poked through the lower abdominal wall. Very common. They can lead to bowel ischemia as well. If this is this opening begins to tighten down and clamp down on that bowel, then that bowel can get necrotic without a blood flow. We'll talk about that in pathology. The small bowel obstruction is a common thing that we scan for, and that's a serious and potentially fatal pathology. It's characterized by loops of dilated proximal small bowel terminating at an area of collapsed bowel. The oral contrast won't pass through the obstruction site, and it causes to include adhesions, hernias, and tumors. So other pathology of the small bowel includes intussusception, which is a portion of the bowel that collapses or telescopes onto itself. An ileus is an area of bowel that has lost normal contractile motion and results in obstruction. This happens a lot in older people and people that on a lot of pain medicine. Crohn's disease is an inflammatory condition characterized by stranding, wall thickening, which is wall thickening or edema and haziness of the fat surrounding the affected bowel. I'll point that out in some in some images. And it usually indicates an infection. All right, the large intestine, the colon, it begins with the cecum, the ileocecal valve where the small bowel heads into it. And then you have on the right the ascending, and then the transverse goes across the abdomen, and the descending is on the left, and then the sigmoid and the rectum portion. The oral contrast needed is, again, greater than 750 milliliters, and you need to wait about 90 minutes at least for barium to reach the rectum. And sometimes rectal barium is used to immediately opacify that rectosigmoid area, and you're going to use about 150 to 250 milliliters of that. It's rare that to use rectal barium. Usually you're looking for the fistula like we saw earlier. So that's about the only time you're going to use those, or to differentiate tumors. There's some indications of for scanning large intestine, or for scanning the belly for large intestine, is polyps, which are adenomas, and those are precancerous growths of the colon. You have colorectal carcinoma, staging and assessment for recurrence of that. Diverticulitis, which is inflammation of pouches in the colon wall, and you can see fat stranding when this is happening. It's most common in the sigmoid, and it can lead to a formation of fistula. You can have IBD, which is inflammatory bowel disease. Crohn's colitis falls under this, which affects the colon. And then ulcerative colitis is also inflammatory bowel disease, and it's characterized by wall thickening and narrowing of the lumen. And then appendicitis is at the cecum, is where the tubular appendix attaches, and this is characterized by periappendiceal fat stranding, contrast enhancing walls. Fat stranding is going to be an indication of infection on just about anywhere you see it in the abdomen. So, appendicolith is calcifications often associated with appendicitis. It's like a stone inside the appendix. They can be quite large too. Enterovesical fistula is an abnormal connection between the bowel and the bladder. Romans has much more information on appendicitis. scanning and protocols, but an interesting table of research studies is located in that table of 21.6, and you take a look at that. Is where several different prep protocols were examined, and of them, one is of particular interest because you're going to encounter this numerous times in your career. A CT protocol has also been advocated that includes the entire abdomen and pelvis but does not incorporate any contrast agents. This examination can typically be performed in 10 minutes or less and does not expose the patient to the potential risk of IV contrast and requires no bowel prep. This technique is often favored in patients with large body habitus because the diagnostic accuracy may be compromised in patients who have little abdominal and intrapelvic fat. So, did you notice the caveat in that statement? Their thinner patients are not really viable candidates for non-contrast CT exams to diagnose appendicitis. You're going to eventually be asked to scan someone for appendicitis with a non-contrast by some ER physician or a mid-level provider just because they don't want to wait on scan time or for the prep time. So now you've got a reason to tell them, look, this is, this patient is thin, then I really need to give them oral and IV contrast because you could misdiagnose this, or radiologists can misdiagnose this on thinner patients. Most often, oral and IV contrast are preferred by the radiologists and the ordering physicians. Although non-contrast abdomen pelvis CT scans are less time-consuming for us and the patient, it may not be in the best interest of the patient. It may not be the best exam suited for the patient. So oral and IV contrast provide the radiologist with the best possible view of internal structures of the abdomen. So that's important, even though it takes a little time, that we do it right. And that we let these physicians know when we're on our own and on the weekends or something, or overnight, look, man, you may be putting us both in a bad spot if we don't get contrast. So, but looking at this slide, you can see, well, there's multiple positions of variations where the appendix can be located in the abdomen. So just to scan the lower pelvis, which is what we used to do, you could really miss the appendix if it's up high. So it makes more sense to scan the entire abdomen pelvis for appendicitis because it can be located anywhere in this area. Most often it's right lower quadrant right here in the McBurney's point, which is a point of where they press in the right lower quadrant to check for appendicitis, and a lot of times the patients will just come off the bed because of the pain. So, but appendicitis protocols or scanning for appendicitis protocols has dramatically reduced the false positives that they were getting, and saved a lot of people from going to surgery. It's cut down dramatically on the surgical exploratory surgery, trying to determine whether it's really appendicitis or not. So it's been a very valuable tool in that for the patients. Okay, so this next, let's see, almost 7 slides, we're going to be talking about the anatomy of the upper abdomen that we just went over. And we're starting about mid-abdomen here, right through the kidneys. And up here we have the transverse colon coming in, the descending colon back here. This is all small bowel. Left renal vein, full of contrast. Here's the left renal artery coming in. Over here, the duodenum is right here coming at the bottom. It's about to connect over here to the jejunum and the ileum. The hepatic flexure is coming up below the liver. The hepatic is liver, and so there's a flexure. And this is just a diagram of the abdomen that you can look for, and it's close to similar to what we just saw in the axial slice here. The head of pancreas is coming up, and there's a superior mesenteric vein, superior mesenteric artery below that, left kidney, inferior vena cava, and then the renal vein coming across. There's the aorta in the back. The duodenum is here, the gallbladder, and then this is liver, the various sections of the liver. Again, ascending colon. It's below the liver. The hepatic flexure was there and starting to come into the ascending colon. This is the erector spinae muscle. We're going to have to learn the muscles as well. Psoas here, erector spinae in the back. This dark little circle here is the ureter that's adjacent to the kidney in it. And if we were up higher, you'd see it connected to the renal pelvis. Superior mesenteric vein showing up here, and then of course transverse colon coming across, and then again small bowel here and here. These three muscles are important: the external oblique, internal oblique, and then the transverse abdominis is the most inner of these three muscles of the abdominal wall. Then here's the psoas muscle. This is the quadratus lumborum. It's always posterior to the psoas muscle, anterior to the erector spinae, which is the big one in the back muscle. And small bowel and the kidney. And this image is showing the ascending colon coming on the right here. The three muscles of the anterior wall. Right common iliac artery and the left common iliac artery is just where the vena cava split. The aorta split. And you have the right, it's split into the right common and left common iliac arteries. And this little portion of colon back here is descending colon. And this is a line called the linea alba, and it's in the middle of the abdomen here. The terminal ileum, okay, if you say so, it's in there. Small bowel mesentery, and what I mean by that is this mesenteric that we talked about with IV contrast enhanced, and that's why it's showing up. The little vessels are here, here, and all of this dark area, or this slightly grayed area, is the mesentery itself, and it's highlighted. It's connected to the small bowel. There's a coronal slice. And you see the pancreas coming across here. There's the fundus of the stomach. It's filled with some fluid. Here's the spleen coming in, splenic vein right here. Portal vein coming up because here's the liver. And jejunum, because here's the duodenum into the jejunum. It's flowing around. You have the ileum that's coming in, and it's making its way back behind here, and it'll eventually come down to the ileocecal valve and connect to the cecum here, and then you have the ascending colon coming up, and there's part of the hepatic flexure. It's not connected because it's just looped back behind there, and we're slicing right through there. Again, here's the some mesenteric vessels coming out, fanning out like this, connecting to the ileum, and the bladder is highlighted here. Of course, the pelvis, symphysis pubis here, femurs. What else can we see? We'll get into the vessels later. Here's the bottom of the heart, and then the diaphragm, of course, is coming across here. There's a sagittal view, IVC, inferior vena cava coming down, and in front of there is the pancreas and the duodenum down here. There's some loops of small bowel. That's what these are, these white areas full of bowel. The head of the pancreas is here, and the stomach is in front of it, and then there's the liver, right atrium of the heart, where the IVC is coming off. The pelvis contains part of the small and large intestines and the male and the female reproductive systems, as well as the bladder and the distal ureters. Indications for scanning pelvis only include the colon, cancers of the colon, bladder, and the reproductive areas, oncologic staging, and fractures. Male reproductive organs are not commonly imaged by CT because they're external and mostly located below the pelvic floor. However, the internal location of the prostate gland and the seminal vessels allows for their visualization during a routine examination of the male pelvis. So the male reproductive organs are external and not routinely examined, but But the seminal vesicles and the prostate are included in the pelvis scans because of their internal position. Undescended testes can sometimes appear internally within the pelvis, and they'll look atrophic. They're at a greater risk of malignancy as well. Then hydrocele or abnormal accumulation of fluid around the testicle. Sometimes those can get really, really big, and if you're scanning through and a patient doesn't know they have that, then you might want to go ahead and add some more scans and just scan through that hydrocele just to demonstrate it all. The prostate is going to be positioned between the pubis symphysis anteriorly and the rectum posteriorly, and it's going to be inferior to the bladder. So you're going to see the bladder. You're scanning from superior to inferior. You'll see the bladder before you see the prostate. Condition of the prostate gland that can be diagnosed with CT is benign prostate hyperplasia, or BPH, and that is an increase in prostate volume which constricts the urethra and it interferes with urination. It's similar in appearance to prostate cancer on CT. Prostate carcinoma CT findings are enlargement of the prostate and pelvic adenopathy. So you're going to have some lymph node involvement, and they'll show up during if there's prostate carcinoma around. And CT appearance of the seminal vesicles, they form a bow tie between prostate and the bladder, and I'll show you that in just a second. So here is the bladder, and then this is a really, really large prostate. It is still inferior to the bladder, but it is superior or anterior to the rectum, and then it would be posterior to the symphysis pubis, which would be coming in right here below the bladder. But that's a pretty large prostate, and that's just benign enlargement, and they can fix that with medication. The seminal vesicles are situated superior to the prostate and between the bladder anteriorly and the rectum posteriorly. So they have this butterfly appearance here. They kind of straddle the rectum, and they're right below the bladder. The seminal vesicles are glands that are responsible for secreting the components of the semen. This is just the sagittal view of the male anatomy, and you can see how the bladder is here and your urine flows out, and then the normal prostate surrounds the urethra here and doesn't constrict, but an enlarged prostate, benign hyperplasia, will constrict the urethra here, and as it enlarges, and restrict blood flow. Urine flow. It can be really painful as well. The female reproductive organs are routinely demonstrated on CT because of their internal location, and they include the uterus, the cervix, the ovaries, and the fallopian tubes. The uterus is typically demonstrated as an oval, homogeneous soft tissue mass positioned between the bladder and the rectum, and the uterine wall is divided in perimetrium, which is the outer layer, the myometrium, it's the middle layer, and the endometrium, which is the inner layer. On CT, the myometrium enhances brightly after IV contrast administration owing to its highly vascular composition. And let's see. The cervix extends inferiorly from the uterus, and it may also enhance after IV contrast as well. Adnexa is a term used to describe an appendage of an organ. The ovaries and the fallopian tubes constitute the uterine adnexa. The ovaries may demonstrate soft tissue or cystic, may demonstrate as soft tissue or cystic in nature and density, and they're located in close proximity to the uterus. The ovaries are often not visualized in postmenopausal women. and inflamed ovaries, or what you look for are inflamed ovaries or ovarian cysts that are causing pain in females, and ruptured ovarian cysts as well. There may be free fluid floating around, and one of those cysts have ruptured. You'll see that as well. Primary clinical indications for CT in female pelvis and the reproductive organs are the evaluation of pelvic pain and the identification of staging or gynecologic masses. So, benign masses can include a leiomyoma. That's a fibroid, or it's also called a fibroid uterus. These are benign, smooth muscle tumors. And then, of course, the ovaries can have ovarian cyst. A cystic teratoma is a dermoid mass consisting of soft tissue, fat, teeth, and bone. Those are kind of strange looking. And the malignant masses can be cervical cancer, uterine cancer, which can be endometrial carcinoma, which is the most prevalent gynecological malignancy. And then you can have ovarian cancer. A lot of times when we're scanning these patients and for a known type of gynecological cancer, we'll insert a tampon. We'll have a patient insert a tampon, and this identifies the vagina and distinguishes it from the mass on CT. So here's some examples of masses. This is a leiomyoma. Here is a left ovarian cyst is here. Here's the uterus. The right ovary is way down here, but then this big old thing here is a left ovarian cyst. And there's a left colon pointed out in the rectum, and you can see how this lining is highly vascular, and it's highlighted the myometrium. And then the endometrial cavity is that little dark area in there. Now over here is a cystic teratoma. It's cystic. You can see it's round, has some dark area in it, so it's probably fluid, and then a little bit of a mass, and then here's some calcification. Could be the teeth or bone, but they're really strange looking masses. And cervical cancer here highlighted. I mean, it's all over. Ovarian cancer, this is a very advanced ovarian cancer. You have a complex right ovarian mass and a complex left ovarian mass, and it's taken up, over half of the abdominal cavity. So this is very advanced ovarian cancer. There's some fluid and ascites around, layering out here around the liver and on the side of the abdomen. And here's uterine cancer. The uterus has a large carcinosarcoma, and it's filling up the uterus here. Okay, so female reproductive anatomy. We have the fallopian tubes here. Here is where they are within the pelvic cavity. And the uterus connects into the vagina and through the cervix right here, down to the in between the urethra and the rectum is the vagina, and then the cervix and the uterus is this shape here. The ovaries are located out here, and this is where you get the ovarian cysts and all of those other cyst types that we looked at. Okay, again, these got about 10 slides to go through here of anatomy, 10, 11 slides of the lower pelvis. We're going to talk about the male and the female in here as well. So in this slice, we're seeing the left common iliac artery here and right here. Here's the cecum. Terminal ilium is coming right into the cecum right there. This is the iliac crest, and then of course the rector spinae again, the psoas muscle, and a little portion of the descending colon here. Here we have the iliacus muscle, which lies alongside the inside of the pelvic ring here, Here is the right common iliac vein, and the right external iliac and right internal iliac are highlighted here, arteries. Here's the transverse abdominis and the gluteus medius. The gluteus maximus is starting to come in right there. Again, here's the external iliac artery. It's going to be running a little superficial to in the leg, and then the right internal iliac artery is going here posteriorly. The right internal vein is here behind it. Kind of hard to see, but the vein and the artery are kind of close together, and we're looking at cross axial slices, so we're not getting a clear coronal view, obviously, of that. The piriformis muscle runs back here deep, anterior to the sacrum. And the gluteus minimus here is giving way to the gluteus medius, and then here's the gluteus maximus coming in the back. These are just some pelvic wall muscle, a diagram of pelvic wall muscles, just to give you some reference to what you're looking at on the CT. You have the psoas major muscle that's back here at this low slice, which is at the symphysis, and so we get to see the iliacus muscle here on the pelvic rim here, and then the obturator internus muscle is within the obturator foramen. Here's the piriformis muscle that's connected to the sacrum anteriorly. And then, let's see, here's the iliac crest, iliacus muscle on the left here. We're getting down lower beside the bladder. You'll see the right external iliac artery, and then the right external vein is right behind it. And then here's a picture of the bladder, and then of course the left external iliac artery and the left external iliac vein here. And then this is the rectum coming down. Sacrum beginning to be the coccyx here, and then here are the femoral head and the acetabulum actually here and here. For the male, this is a slice for the male anatomy. It's showing the seminal vesicles here coming in on both sides, right behind the bladder. And this is the sartorius muscle here. It'll be coming in over here in just a second. There it is. So we have the prostate, which is here, and then here's the bladder. The ischial spine bone, superior gemellus. I'm not sure, that's a muscle, but I'm not sure where it's at on the other side. I guess right in here. Iliopsoas muscle coming here, and then the rectus femoris is starting to form here, and the tensor fasciae latae muscle right here. Make up the leg muscles here. All right, some more male anatomy. Here's the prostate down low, below the bladder, posterior to the symphysis pubis, and then anterior to the rectum, which is coming here. There's the coccyx, the ischium, the greater trochanter, the femoral head, and then the acetabulum, of course, right here. Superior pubic ramus. Okay, we get into the female anatomy. There's the rectum, and for reference, and here's the uterus. Again, the uterus with the uterine cavity, dark area in there, and highlighted myometry. You can usually tell that it's got this dark area in it, that you're looking at the uterus and not just some crazy mass out there in the middle. The vagina is coming in right below there, and then the rectum will be posterior to that. Again, here's the uterus. Vagina's down in here. Here are the ovaries coming in here and here. Little dark cystic looking things. And the round ligament which holds all that together. And uterus. We're below uterus. uterus into the vagina that's headed out, symphysis pubis, and then the rectum here, femoral head and neck, acetabulum. There's a coronal view of the pelvis for bony trauma, or in this case, there's a huge, it's like a cystic mass. It's taken in the bone here. But you have the ilium, femoral head, greater trochanter here, lesser trochanter there, ischium is coming in here, and then the pubic ramus there. All right, so that's wraps up our look at the GI system and male and female reproductive system as well. And we'll move on to some angiography studies of the belly next time.